As you saw in the case study of a 42-year-old female Hannah who was of Asian origin, she had certain specific symptoms, specifically hyperbilirubinemia, jaundice, icterus, along with anemia. So, how do we evaluate such patients? How do we diagnose the Hannah on the basis of our clinical examination and the physical examination and the lab values which we have? And how do we further treat Hannah? And what is important in counseling the family of Hannah in regards to her presentation? This is our major topic of discussion today. We are going to continue our discussion of the anemias in this internal medicine section of hematology. And today, a specific topic of discussion are the hemolytic anemias, specifically the inherited hemolytic anemias. Now, the hemolytic anemias can also be acquired, as we are going to see the classification in the coming slides. But today, we are going to majorly focus on the inherited types of hemolytic anemias, specifically more likely the enzyme deficiencies. Now, as the words implies, hemolytic anemias. These are the anemias which is primarily because of hemolysis. The hemolytic anemias can be classified into three easier subtypes for the matter of understanding and discussion. The hemolysis resulting in anemia can either be because of the decreased production of the red blood cells in the bone marrow, that is the anemia of production, or it can be because of an increased destruction of the RBCs in the peripheral blood film. And the third type is because of an acute blood loss. Now, we talked about the decreased production of RBCs or the anemia of production in the hemoglobinopathies when we were talking about the normocytic anemias and the iron deficiency anemias lecture. So today, our major focus will be on the increased destruction of the RBCs along with acute blood loss going forwards. Now let's start off by classifying the hemolytic anemias. As I told you in the start of the lecture, that we can broadly classify the hemolytic anemias as either hereditary or acquired. In the hereditary, the two major and easier ways to classify the hereditary types of hemolytic anemias are either the anemias with an intracorpuscular defect or the anemias in which there is an intrinsic defect in the RBC. Or the second type can be anemias in which there is an extrinsic defect, which we are going to talk about. Now let's talk about the intracorpuscular defects or anemias with an intrinsic defect, in which something is wrong within the RBCs that leads to their destruction or hemolysis. They can be either the hemoglobinopathies, which we discussed in the lecture on the iron deficiency anemias, for example, the thalassemias, alpha and the beta thalassemias. It can be disorders of cation transport. These are very rare conditions in which there are ion channel problems, and that leads to an imbalance of the ions within and outside of the RBCs. There can be an enzymopathies, which is the major topic of discussion today, specifically enzymes involved in the glycolysis pathway and the hexose monophosphate shunt, which are very important for the survival of RBCs. Or there can be certain membrane or cytoskeletal defects. This is related to the integrity and the structure of the RBC. If there is any problem in the membrane or the cytoskeleton of the RBCs will be prone to destruction, and they will not be able to acquire their proper shape when passing through the splenic macrophages or the macrophages within the liver. The other types are the hereditary anemias with the extracorpuscular defects. These are basically the anemias in which there is no problem within the RBCs, but there is some problem, some outside factor that leads to destruction of the RBCs. The important one here to discuss are the familial or the atypical hemolytic uremic syndrome. Now, hemolytic uremic syndrome, there are various varieties of this hemolytic various syndrome, but the one which we are concerned today in the hemolytic anemia section are the familial or the atypical hemolytic uremic syndromes. Let's look at the other sides. The hemolytic anemias can also be acquired. The hereditary anemias generally present earlier on in the patients, and the presentation is very variable. In some patients, there are very pronounced symptoms. They can require blood transfusion, but generally and mostly these patients can also be very silent unless there is a dominant mutation leading to hereditary anemias in which the patient can have a severe presentation. Contrary, on the other side, on the acquired side of anemias, there can also be any intrinsic defect or the intracorpuscular defect that is within the RBCs. In this, the important one to understand is the paroxysmal nocturnal hemoglobinuria, which we abbreviate as PNH, or there is a whole list of extracorpuscular defects in which factors outside the RBC lead to the destruction of the RBCs within the vessels. These can either be a mechanical destruction, which we call the microangiopathic anemias. For example, in someone who has an aortic valve sclerosis, in which the cells are not able to pass normally as in a person with an aortic valve. So this can lead to mechanical destruction of RBCs at the level of the aortic valve, and this leads to a microangiopathic hemolytic anemia. Similarly, certain toxins can cause extracorpuscular hemolytic anemias. Certain drugs, for example, the nitro or the sulfur drugs, can cause hemolytic anemias. And certain types of infections, certain inflammatory diseases can also lead to the extracorpuscular defects, which in the long run can lead to hemolytic anemia. And finally, the important one, which we are going to discuss in the coming lectures, are the autoimmune anemias, in which there is certain immunological problem that lead to RBC destruction. Our major focus is towards the hereditary anemias today, and in the second part of the lecture, or in the coming lecture, we are going to discuss about the acquired types of anemias, specifically focusing on the autoimmune hemolytic anemias. Now, before going into the further details, let's have a general outlook of the clinical features of hemolytic anemias on the whole. If you understand the pathophysiology behind these clinical features, the whole lecture will be very easy, because these are the features which are going to be predominant in all the types of anemias. So, as with other types of anemias, the patient will have jaundice or increased bilirubin. This is because of the destruction of the RBCs. There are two types of places in which the RBCs are going to be destroyed. Either they are going to be destroyed outside of the vessels, in which is called extravascular hemolysis, or there will be an intravascular hemolysis. In the extravascular hemolysis, the places where defective RBCs or the RBCs which have some problems are going to be hemolyzed are the splenic macrophages, or the macrophages within the liver, and to some extent in the lymph nodes. These are collectively called the reticuloendothelial system. So when the macrophages within the spleen destroy an RBC, it leads to hemoglobin release. As we know that hemoglobin is composed of heme and the globin parts. Globin is basically a protein or an amino acid. So when hemoglobin is released, it is broken down into heme and the globin parts. Globin is further broken down into amino acids, and the body takes up those amino acids for further use. The heme part is further broken down into iron and protoporphyrin. The iron is taken up by the body and stored for further use, because iron is an essential nutrient for the body. And that leaves us with protoporphyrin. So that protoporphyrin is further broken down into bilirubin. That bilirubin is unconjugated bilirubin. It is not water soluble. It is released into the plasma, where it combines with various types of bilirubin binding proteins, or the transport proteins. So this bilirubin is taken up by the liver, and it is further conjugated and secreted into the bile. So this is the whole pathophysiology behind the development of jaundice. The liver has a limited ability to conjugate the bilirubin over a period of time. For example, if liver can conjugate 10 molecules of bilirubin in a day, just for the matter of understanding, and if there are 50 molecules of unconjugated bilirubin coming up, this leads to saturation of the liver, and that leads to the buildup of the bilirubin in the blood or the plasma. And that is what that bilirubin, that unconjugated bilirubin, is the one that manifests as jaundice, or the yellowish discoloration of the skin. And we can very much see it at the beginning in the sclera of the eye, the yellowing of the sclera. So this is the pathophysiology behind the development of jaundice. Along with that, there will be anemia because of the hemolysis that leads to pallor, or the pale skin. The spleen will be enlarged because the splenic macrophages are working overtime. The spleen is enlarged because it is leading to hemolysis. The macrophages within the spleen, they are enlarged, that lead to an overall enlargement of the spleen, because they're working overtime. They are leading to clearing of the RBCs, which are normally not cleared up in a normal person. So they are basically in overworked form, and that leads to their enlargement. Along with that, just as we saw in thalassemia, the hematopoiesis within the bone marrow that is generally increased, because to counteract for the anemia, the the bone marrow starts producing more RBCs, and specifically the bone marrow produces reticulocytes, which are the earlier RBCs. So this leads to expansion of the bone marrow in various types of bones in the body, specifically in the long bones of the arms and the leg. It can also be evident in the skull, especially in patients with thalassemias. The characteristic feature is the bossing of the skull, enlargement of the skull. This is because of increased erythropoiesis within the bone marrow. One important thing to understand here as well is that in the anemia of destruction, as we talked about, the reticulocyte response is generally less than 3%. And in these type of anemia, the inherited hemolytic anemias, which are anemias of destruction, the reticulocyte count will be enlarged. It will be greater than 3%. As you saw in that case study of Hannah, the reticulocyte count was 25%. And then we corrected for the degree of anemia. The way we correct it is we divide the hemoglobin by the 45, which is generally the hematocrit in a normal person, multiply by the reticulocyte count. In the case study, the reticulocyte count was 25 and the hemoglobin was 9. So after doing the calculation, we divide 9 by 45, it leads to 1/5. And when we divide 25 by 5, we have a corrected reticulocyte count of 5%. Now this 5% corrected reticulocyte count, what does it show? It shows us that the anemia in this patient is basically of destruction. The bone marrow is working fine. If the bone marrow had some issues, then the reticulocyte count must have been less than 2%. What are the reticulocytes? Reticulocytes, as we talked about in the anemias during the iron deficiency anemias, reticulocytes are the earlier RBCs which are being produced in the blood. They have a primitive, some of them have the RNA evident in their in the RBCs, which can be visible with the help of a stain like a supravital stain. And these RBCs are generally present in the blood circulation in a concentration of about 2%, not more than that. But in someone who has anemia, and so when the body has anemia or the destruction of the RBCs, or in a general there is a decrease in the RBC count, the body tries to compensate for that by increasing the erythropoiesis or the production of RBCs in the bone marrow. In this increased production process, the body quickly dumps out the newly formed RBCs before they have matured. And these are the RBCs which are termed as reticulocytes. Once they are in the blood circulation, they take 24 hours to get mature. And after the 24 hours, they are converted into the normal mature RBCs, which lack a nucleus, which lack these RNA threads around them, which are the ones by which we diagnose the reticulocyte. So it is very important to calculate the reticulocyte count after correcting for the anemia in any patient which presents us with a suspicion of a hemolytic anemia, because it helps us in identifying the cause of the anemia, whether the anemia problem lies within the bone marrow or whether there is some problem outside the bone marrow that has led to the destruction of the RBCs. Now, as with that patient Hannah, we can see that the corrected reticulocyte count is about 5%. That means that has ruled out all the anemias of production. And now we can focus on the anemias of destruction, or the anemias in which the RBCs are being destroyed outside the bone marrow. Now let's talk about the general lab features which are going to be common in all the types of hemolytic anemias. To start off, the reduced hemoglobin level, which is a definition of anemia. The hemoglobin level will be generally lower than the 13 milligrams per deciliter, 13 grams per deciliter, sorry. Now the MCV is generally in the anemias on a whole, the hemolytic anemias are generally the normocytic anemias, in which there is a normal MCV 80 to 100. But in some cases it can be on the higher side, so it can be a normocytic or a higher elevated MCV, in which we have a combination of normocytic cells with certain macrocytic cells. The MCH, or the mean cell hemoglobin concentration, can also be elevated. Specifically, the MCHC, the mean corpuscular hemoglobin concentration, will be elevated in this hereditary spherocytic anemia, which is a very important anemia, which we are going to talk about in the coming slide. Along with that, the reticulocyte count will be increased, as I explained in the previous slide. There will be an elevated bilirubin because of the breakdown of the RBCs, LDH level will be increased because when the RBCs are going to be broken down, the LDH will be released from the RBCs. And one important thing to discuss here are the heptoglobin. What is heptoglobin? Heptoglobin is basically a scavenger molecule which is present in the plasma. As I told you in the previous slide, there are two ways to destroy an RBC to cause hemolysis. The one was the extravascular hemolysis, which I explained, which happened generally in the reticuloendothelial system. The other one is the intravascular hemolysis. In intravascular hemolysis, the RBCs are being broken down within the blood vessels. And when the RBC breaks down within a blood vessel, it releases its hemoglobin into the circulation. And that condition is called hemoglobinemia, which means that increase in the hemoglobin concentration in the blood. Whenever we have anemia at the end of any term, that means within the blood. So there is a scavenger molecule called heptoglobin. Whenever the hemoglobin is being released, that heptoglobin combines or scavenges the hemoglobin and avoids its accumulation within the plasma, because hemoglobin within the plasma can be very toxic. It can get deposited into various areas and it can lead to a lot of issues. So that heptoglobin concentration in turn, because of combining with hemoglobin, generally the heptoglobin concentration reduces in the plasma. When the heptoglobin is overwhelmed and there is not enough of the molecule to scavenge the hemoglobin, that hemoglobin then goes on into the kidneys. It can pass on in the urine in the form of hemoglobinuria, and it can also lead to hemosideruria at the level of the kidneys when the renal collecting tubules. So these are the two major mechanisms of hemolysis. In some types of anemias, extravascular hemolysis will be predominant. In certain other types of anemias, there will be predominance of the intravascular hemolysis. While the pictures of both the anemias will be evident, but one type will be evident. I'm going to tell you with the certain types of anemias what is the major types of hemolysis evident in these type of anemias. So these lab features are very easy to understand if you have a basic understanding of the hemolysis pathophysiology. All right, now let's talk about the two major enzymes which we are going to discuss today. Before understanding those enzymes, it is important to understand this pathway, which is called the Embden-Meyerhof pathway. It is also simply termed as the glycolysis or the glycolytic pathway. It is a complex slide and you don't need to remember all the details. I'm going to play the slide slowly and we are going to focus on the areas in which we have to focus or understand. Now, the basic mechanism of glycolysis is generation of ATP. So when the body has enough glucose, the various cells in the plasma, it lead to this glycolysis pathway leading to the generation of ATPs. The ATPs are, if the cell lacks the mitochondria like the RBCs, so the ATP production is generally very much reduced. It is about 2 ATPs produced in cells without the mitochondria, but in other cells which have mitochondria, a lot of ATPs can be produced because of the citric acid cycle. So we start off with by phosphorylating glucose to glucose 6-phosphate, and this is an important enzyme to understand here. Here we can merge the two pathways. The other pathway is the hexose monophosphate shunt. What happens with this pathway is this pathway leads to the generation of this important chemical called the NADPH. This NADPH is very important to convert the glutathione into its reduced form. This reduced glutathione, termed here as GSH, is very important to keep the integrity of the RBCs, because this reduced glutathione basically acts as a free radical scavenger or a free radical trapper. So this reduced glutathione converts the free radicals, specifically the hydrogen peroxide, into water. Because the RBCs don't have catalase enzyme and they cannot convert the hydrogen peroxide with the help of catalase, they are dependent on the production of this reduced glutathione. And this reduced glutathione is in turn dependent on the production of this NADPH. This is going to be more clear in the coming slide when we are going to talk about the G6PD or this enzyme, glucose 6-phosphate dehydrogenase deficiency, in the detail. So just at this point, understand that this enzyme G6PD is very important for the generation of glutathione to help maintain the integrity of the RBCs. Because if the peroxide, the hydrogen peroxide accumulates, it leads to membrane damage, and that membrane damaged RBC will be prone to hemolysis by the spleen and or inside the blood vessels. The other steps in this process are not relevant to you, and I'm just going to play them very slowly. And now we are going to focus on what is the other enzyme in this pathway, which is important for you to understand or memorize. These are the whole steps involved in the conversion of one product to the other. And the other one in which the other enzyme which is important for your understanding and which is relevant to the discussion of the hemolytic anemias is this enzyme, the pyruvate kinase enzyme. It basically converts the phosphoenol pyruvate to pyruvate, and that leads to the generation of ATPs. And whenever we have someone in which there's a genetic deficiency of this enzyme, the glucose cannot be converted into pyruvate. Pyruvate is the basic product that leads to generation of ATPs. So there is a buildup of the products here, and some of these products can get shunted off and lead to an accumulation of the 2,3-BPG. As we all know, that 2,3-BPG leads to the rightward shift of the oxygen hemoglobin dissociation curve, and it leads to unloading of the oxygen. So this can also mask some characteristics of anemias which are evident in the pyruvate kinase deficiency. We are going to discuss these enzymes in the coming slides. So this was just an overview of the whole general pathology involved. The two enzymes which I want you to remember in this slide are the G6PD, and the other one is the pyruvate kinase, because these are the two major enzymes which lead to and the enzymatic types of hemolytic anemias, the hereditary types. Now let's understand the concept of compensated hemolysis versus uncompensated hemolysis or the hemolytic anemias. Generally, when there is hemolysis in the body, hemolysis of the RBCs, the kidneys increase their production of erythropoietin, or this erythropoietin is a product that leads to stimulation of the bone marrow, and it generally, if the hemolysis is on a very short scale or a small scale, and there is not enough destruction of the RBCs to cause anemia, the released erythropoietin stimulates the bone marrow to release further RBCs, and that compensates for the hemolysis, and the anemia will not be clinically evident. This happens a lot of times in which the patient doesn't even realize that they have some hemolysis going on. This is termed as a compensated hemolysis, in which the increased erythropoiesis compensates for the increased RBC destruction. But if we have a condition in which the hemolysis is either on a very large scale or it is very acute or very brisk in a very short period of time, and the bone marrow does not respond adequately or is not able to compensate for it very quickly, that will be evident as a hemolytic anemia on a examination to us. So hemolytic anemia develops when there is increased erythropoiesis and it does not or it cannot compensate for the increased RBC destruction. So this is important to understand the development of the hemolytic anemias. Now let's talk about the inherited hemolytic anemias, which are majorly concerned with the membrane-cytoskeleton complex. To understand that, let's have an overview of the RBC membrane. It has a lipid bilayer, and it has a lot of proteins, some of which are embedded in the lipid bilayer, some of which are intracellular, some of which are intracellular projecting outside. You don't need to remember all the types of proteins. The important ones I'm going to highlight here, and the important ones which are relevant to the hemolytic anemias. The most abundant protein which is present in the lipid bilayer are the band-3 proteins. And these band-3 proteins are the ones which interact with the cytoskeletal membrane inside the cells. The cytoskeleton is the major important structure which maintains the integrity of the RBCs. The other proteins which are important at the level of the lipid bilayer are these red and blue stripes which you are going to see. These are the GPI anchoring proteins. These anchor various types of proteins to the RBC membrane. For example, here it is anchoring an acetylcholine E channel, here it is anchoring a CD59, and here it is anchoring a CD55. These two are complement products, and these are important specifically when we are going to talk about the paroxysmal nocturnal hemoglobinuria. There is a GPI anchor problem in those patients, and acetylcholine E is very important for the interaction of the acetylcholine. But band-3 are the most abundant proteins in the lipid bilayer, and these are the ones which are going to interact with the cytoskeleton filament. These are the cytoskeleton filaments which maintain the integrity of the RBCs or maintain the proper structuring of the RBCs. Along with that, there are certain anchoring or the teeth ring proteins. The important ones here are the N-chirin, the band 4.2, and the other ones are the band 4.1. These basically interact with these spectrin cytoskeletal structures. The major abundant protein in the cytoskeleton within the plasma, this major cytoskeletal protein is the beta spectrin. There are various components of this beta spectrin. It has beta chain, it has alpha chain, the spectrin protein. Then there are tropomyosin, tropomodulin interactions, actin protofilaments. The important thing is that spectrin cytoskeletal proteins interact with the band 3 proteins via these N-chirin molecules. These N-chirin molecules are the ones which I want you to remember, because these are the ones, the teeth ring or the connecting proteins which are deficient in the hereditary spherocytic anemias or the hereditary spherocytosis. So when this anchor is not present, this leads to an overall disruption of the cytoskeletal and membrane integrity, and the cell changes its shapes from a normal biconcave structure to a spherocyte, to a round globular structure. And when the cell changes its shape, there are certain problems with that regarding the cell integrity or the cell maintenance of the various ion transport or the cell ability to carry the various products. So the important thing here to realize are the take-home point in this slide are these three. You have to remember the band 3, which is the major lipid bilayer protein, the spectrin, which is the major cytoskeletal protein and what connects these two are these N-chirin proteins. The important one, the major one is the N-chirin or the 4.2 or the 4.1. Now let's talk about the hereditary spherocytosis. How does it look on the film? As you can see here that this is a normal RBC in which there is a normal central area of pallor. And here you can see an RBC which is just slightly larger than a normal RBC, but the central area of pallor is absent. This normal RBC has a general biconcave structure, but this RBC in which there is no central area of pallor, for example, just like this RBC is round or globular, and that is termed as a spherocyte. When we see these spherocytes on a peripheral blood film in abundance, as you can see here, we term it as a hereditary spherocytosis. And this is generally because of that N-chirin protein defect that anchors the RBC membrane to the RBC cytoskeleton. If that anchor is is not present, there is a gap or there is no connection between the RBC membrane and the cytoskeleton. So the overall biconcave structure of the RBC changes to a globular or a spherical structure. If N-chirin is a major protein which is absent in the hereditary spherocytosis. If there are deficiencies of certain other types of proteins, for example, the band proteins in the teeth, in the anchoring proteins, that can also lead to hereditary elliptocytosis, in which in spite of the the spherocyte, there is an elliptical formation of the RBC. As you can see, the RBCs are elliptical. So that leads to a condition called hereditary elliptocytosis. This is a very rare condition. Spherocytosis is more common than elliptocytosis. And spherocytosis will be major one to understand. Now, this elliptocytosis can also develop in someone on an acquired basis without a genetic cause, and it is also very rare, in which there will be very few elliptocytes, just like one is here, one is present here. This is not something which you should be very much concerned about. You should be focusing majorly on the hereditary spherocytosis. This is just for the matter of completion. Now let's talk at the genetic level. This slide is a bit very complicated. It has a lot of genes. I just want you to take home point from this slide is that the various types of genes interact with each other, and the various types of genetic defects, be it these complex, the SLC4A1 gene or the EPB4A1 gene, they all interact together to lead to this hereditary spherocytosis or the hereditary elliptocytosis problem. So, as we all know that hereditary spherocytosis, it is basically an autosomal dominant disorder. As in the case lecture which we started out, in the case study which we were discussing the female Hannah, it was very important that after we had diagnosed that patient, she might have hereditary spherocytosis. Just look, just as we are going to discuss in the coming slides, it is very important to screen the family of that patient to look for the other relatives whether they have this problem as well, because hereditary spherocytosis is an autosomal dominant problem, and it has a varied presentation. In someone like Hannah, it has been presenting with certain signs and symptoms, but in other patients, it might be very clinically non-significant, lead to very minor degree of anemias. So all these genes interact with each other to lead to these problems. It can either cause hereditary spherocytosis, abbreviated here as HS, or hereditary elliptocytosis, abbreviated as HE, or there is a rare condition also called hereditary stomatocytosis, in which there is a central area of pallor, just like a moon shape. So this is called hereditary stomatocytosis. Just understand that at genetic level, the various types of genes interact with each other to lead to the development of these types of anemias. Now let's talk about the hereditary spherocytosis. The major defect in hereditary spherocytosis is the anchoring protein problem, specifically the ankyrin defect. This leads to disruption of the integrity of the RBC and the cytoskeleton membrane. The RBC shape changes from a biconcave shape to a spherical shape or a sphere, and that spherical RBC is very much prone to destruction. This destruction of the RBC within the macrophages of the spleen is the one which causes hemolysis and leads to anemia. Otherwise, the spherical shape is able to carry the hemoglobin, carry the oxygen combined with the hemoglobin very specifically. And if there is no destruction at the level of the spleen, the body will not even realize that there is a problem. So this is the major underlying pathophysiology in hereditary spherocytosis. The clinical presentation will be the same general features which we discussed. There will be jaundice. The spleen will be enlarged because of destruction of the RBCs in the spleen. Because of increased availability of the bilirubin within the bile, that leads to saturation of the bile with the bilirubin, and it can lead to gallstone formation, specifically the pigmented gallstone formation. And this can even lead to a development of cholecystitis in these patients. As in the regards of Hannah, we discussed about that she had a history of cholangitis, and that might be because of the gallstone formation. She also had an enlarged spleen. There was jaundice evident. There was normocytic anemia with an increased MCHC, or the mean corpuscular hematocrit concentration. This is because when the size of the RBC shrinks, or it made more spherical, the hemoglobin within it, the concentration of the hemoglobin relative to the surface area increases, and that leads to an increase in the MCHC concentration. So all of these signs and symptoms are present with Anna, and so the empirical diagnosis which we were able to make during that case study was the diagnosis of hereditary spherocytosis based on these clinical features. How do we now diagnose? The next question to ask in the case study was how do we diagnose this condition? There are a few important tests here. The one thing important is to evaluate the family history, because it is an autosomal dominant disorder, and so any relative can present, first degree relative can also have an autosomal dominant mutation. Otherwise, there can be a de novo mutation arising in this patient. Certain recessive forms of hereditary spherocytosis, which are very rare, can also be present. The important test or the screening test available to us is the osmotic fragility test, which is the major important one which you have to remember. What happens is when the RBC becomes the spherical or a spherocyte, its ability to counteract the external stresses decreases. And if we place that RBC in a hypotonic solution in which there is an increased amount of water, that water gets into the RBCs, and because the RBC is a sphere rather than a biconcave structure, there is a limited space in the RBC to contain that water. And when the water concentration increases up till a threshold, it can lead to bursting or the destruction of the RBC or the hemolysis. So this osmotic fragility test is the major screening test, and it can help us in giving us a presumptive diagnosis of hemolytic hereditary spherocytosis, and then we can confirm it afterwards with a genetic analysis to evaluate for the autosomal dominant genetics. The other tests are now obsolete. Just for the matter of completion, the acetylcholesterol lysis test was being done historically, There was an EME binding test which was also performed historically, and finally we can also evaluate these patients by the help of gel electrophoresis. But the important one here to remember is the osmotic fragility test in regards to the hereditary spherocytosis. So this is how we were going to diagnose Hannah, that 42-year-old female patient. Now, after diagnosis, how do we treat it? The major problem in hereditary spherocytosis is because the spleen is destroying the RBCs. If the spleen was not destroying the RBCs, then there is no anemia. So the curative treatment is splenectomy. We remove the spleen, and after the removal of the spleen, there will be no anemia, and the RBCs, the spherocytes, will be moving around in the bloodstream, but they are able to carry the oxygen and they are able to perform their functioning. So splenectomy is the curative treatment in this patient. Splenectomy is done in those patients in which the anemia is very debilitating, or it leads to very lower hemoglobin concentration, and the patient has very pronounced symptoms. With the splenectomy, it is important to before doing splenectomy, it is important to vaccinate the patient with the anti-pneumococcal vaccine, because once the patient has no spleen, they are prone to the encapsulated bacteria. And after the splenectomy, we give a penicillin prophylaxis as well to these patients to avoid the development of infection. And if the patient, in certain patients who have developed gallstones, which have led to the development of cholecystitis, cholecystectomy can be done by the laparoscopic approach. So this is the treatment modalities which we have. And these are the treatment modalities by which we are going to treat Hannah, because she had clinically evident and a severe anemia. And it is important also to screen the relatives of the patient. Because of the autosomal dominant mutation, we are going to screen the parents and the first degree blood relatives of Hannah as well. That concludes our discussion of the hereditary spherocytosis. Now let's just quickly look at certain disorders of cation transport. These are very rare. In certain types of hereditary problems, there can be a cation transport problem with the ion channel that leads to an increase in the intracellular sodium concentration. And along with that, there will be a concomitant loss of potassium. That can lead to development of pseudohyperkalemia in this patient. We talked about pseudohyperkalemia in patient when we were discussing the potassium abnormalities in the electrolyte section of the internal medicine. That pseudohyperkalemia can be an accidental finding on a lab examination, and the patient will have absolutely no problem, and that you don't have to do anything about that. That can also lead to development of stomatocytosis, in which stomatocytes are present in the peripheral blood film, or because of the loss of potassium and increase in the intracellular sodium concentration, the cells might be dehydrated, and that has led to the development of xerocytosis or the cryohydrocytosis. These terms are used for the dehydration of the RBCs. So this is all you just have to realize or understand regarding the cation transport problems. The other major topic of discussion today are the enzyme abnormalities. Specifically, we talked about the enzyme abnormalities regarding the glycolytic pathway. There is a whole list of enzymes like the hexokinase, the important, or the glucose 6-phosphate isomerase. The important one here, which you are concerned with, was, as I told you, was the phosphoglycerate kinase or the pyruvate kinase enzyme, the last one. Pyruvate kinase is the one which you, regarding the glycolytic pathway or the Embden-Meyerhof pathway, is the one which you have to remember. And along with that, the redox pathway, specifically the hexose monophosphate shunt pathway. The important one here to remember is the glucose 6-phosphate dehydrogenase enzyme, because this is the most common and these lead to all the problems. The other enzymes are basically complementing the pathway, and their deficiency is either very rare or non-clinically evident. So another one is the nucleotide metabolism. The important enzyme here to remember is the pyrimidine 5 nucleotidase enzyme. So these three enzymes, pyruvate kinase in the glycolytic pathway, glucose 6-phosphate dehydrogenase in the redox pathway, and the pyrimidine 5 nucleotidase in the nucleotide metabolism is which are the major enzymes which we are going to discuss. Now let's start off by discussing about the pyruvate kinase deficiency. As we saw, that pyruvate kinase catalyzes the last step of the glycolysis, in which there is formation of ATPs. The phosphoenol pyruvate is converted to the pyruvate. If there is a pyruvate kinase deficiency, there is a deficiency of the generation of ATPs. And ATPs are very important for the overall integrity of the RBCs. The RBC is dependent on the development of our ATPs. So that leads to problem with the RBC membrane formation and the cytoskeletal membrane formation, and that makes the RBC prone to destruction. So these patients, as the RBC passes through the splenic macrophages, they can get entrapped there and they can get destroyed by the splenic macrophages. That leads to the development of anemias. Majorly, this anemia is clinically very silent or very the hemoglobin is not very greatly reduced to cause any significant clinical problem. There might be mild hemolytic anemia, but in certain patients, the pyruvate kinase deficiency, which is an autosomal recessive disorder, can be very severe to the degree that we might have to give blood transfusion to these patients. So the extent of the problem is varied from mild hemolytic problem to a very severe problem leading to transfusion. Along with that, with any other type of hemolytic anemia, there will be a reticulocyte count increase or a high reticulocytosis because the bone marrows are doing their job by secreting the newly formed RBCs into the plasma, which are the reticulocytes. Okay, now how do we treat it? Because there is a problem with the ATP formation, we give the cells oral folic acid to compensate for that, to compensate for the energy. If there is a problem with the hemolysis, very much severe, leading to the loss of greater number of RBCs to the extent that the hemoglobin is greatly reduced, we might have to give blood transfusion to these patients, specifically if the hemoglobin falls to the levels of 6 and 7 grams per deciliter value. Along with the blood transfusion, it is important to consider the iron overload with the blood transfusion, and that we give these patients iron chelating drugs like the deferoxamine or the deferrox, as we talked about in the iron section. And finally, since the spleen is destroying the pyruvate kinase, the RBCs, because of the pyruvate kinase deficiency, splenectomy is the curative treatment in a highly symptomatic patient. So the basic theme is the same in all the types of anemias regarding the treatment and the clinical features. We just have to understand the pathophysiology of the development of the anemias. And the curative treatment in someone who has a candidate and who has a donor is the bone marrow transplantation. But that is in the earlier stage, and it is not very commonly done in these patients because it is very difficult to find a proper matched donor with the HLA typing. But that is the definitive curative treatment in these patients, and you don't have to remove the spleen in these patients if you are going to find out a bone marrow transplant. Let's talk about certain other glycolytic enzyme problems, and we are going to talk about the clinical features on the whole, which we are going to see. There might be development of the neonatal jaundice because of the excessive bilirubin. The spleen is enlarged. The jaundice of the increased bilirubin can get deposited in the brain and can lead to connectaris or the mental retardation, problems with the cognition in the cerebrum. There might be a normo to a macrocytic anemia. Generally, the anemia is normocytic, but because of certain cells being enlarged, it can also have a macrocytic picture, or it can be on the higher end of the normal. And reticulocytosis, and it is common in all the types of hemolytic anemias. And hyperbilirubinemia, because of the breakdown of the RBCs by the macrophages, that in turn leads to the neonatal jaundice. So these are all the same signs and symptoms which we discussed in the general part, and these are going to remain the same. So these anemias are very easily you are very able to understand these anemias if you have a basic understanding of the pathology underlying each type of anemias. One important enzyme abnormality to discuss here is the G6PD deficiency, or the glucose 6-phosphate dehydrogenase deficiency. Glucose 6-phosphate dehydrogenase is a very important enzyme because it leads to the development of NADPH. This is the step that G6PD carries out. It leads to G6P is converted into 6-phosphoglucorate, and in turn the NADP is converted into NADPH. Now this NADPH is very important to reduce the oxidized form of glutathione. This is abbreviated as GSSG. This is oxidized glutathione. And the oxidized glutathione is injurious to the body, and we have to convert it into a reduced form. To convert the oxidized form to a reduced form, that is catalyzed by an enzyme called glutathione reductase, and glutathione reductase requires NADPH. So NADPH generation is very important to convert the oxidized glutathione to its reduced form, and that reduced form in touch neutralizes the hydrogen peroxide. This is a free radical, and that leads to membrane damage. It leads to polymerization of the RBC, or the concentration of the RBC, concentration of the hemoglobin, polymerization of the hemoglobin molecule. So it is very imperative, because the RBCs does not have a catalase enzyme to convert the H2O2 to H2O. They are dependent on GSH, or the glutathione reduced form, to neutralize this free radical. This reaction is carried out by glutathione peroxidase. So the first step is very imperative for the subsequent steps. And if we have a problem here in the G6PD production, it leads to problem in all the steps downstream and leads to accumulation of the hydrogen peroxide. And that hydrogen peroxide in turn leads to membrane damage. This is the underlying pathophysiology. This NADPH is also important in preventing the development of methemoglobinemia. Methemoglobinemia can develop if there is some oxidative damage or oxidative agents that lead to oxidation of the iron from the ferrous to the ferric state. And that methemoglobinemia, as we talked about in the previous lecture, leads to problem with the carrying of oxygen or the unloading of oxygen. And similarly, the oxidative agents release to the production of this H2O2 as well. So G6PD is an imperative enzyme to carry out all these processes. What are the important or the significant factors that can lead to problem in patients with G6PD? First, G6PD is an X-linked recessive disorder. So it is primarily evident in the boys, in the male population. And for females to have this problem, they have to be homozygous. Secondly, it is primarily present in the Mediterranean variant in the black population or the African Americans. So in the Mediterranean variant, for example, in the Italy or in the other Mediterranean areas, it can lead to a severe hemolytic anemia. While in the African American population, it is generally controlled and the anemia is generally episodic, and it develops under certain oxidative stresses. What are the important oxidative stresses? Either when there is development of acidosis, or there is oxidation, or there is hypoxemia. Certain types of beans like the fava beans can stimulate this hemolysis, specifically in the hemolytic variant, and then certain other types of drugs can also cause this hemolysis, which we are going to talk about in the coming slides. What are the signs and symptoms in patient with G6PD deficiency? There will be development of the neonatal jaundice because of increase in the bilirubin, unconjugated bilirubin, and the liver is not able to compensate to conjugate that much bilirubin in the neonate. It has not developed the enzymes for conjugation yet. Similarly, because of the oxidative stress, there can be an acute hemolytic anemia episode. Conjunctivitis, or the increased bilirubin, can deposit in the brain, leading to conjunctivitis, which can lead to the neurologic damage. Then certain non-specific symptoms like malaise, weakness, or abdominal pain can develop. The important thing is that the episodes of hemolytic anemia in these patients start off with hematuria. The patient will have back pain with hematuria or hemoglobinuria. In the hemoglobin is present in the blood because the intravascular hemolysis is the major underlying mechanism in these patients. The RBCs are destroyed within the blood vessels that lead to hemoglobinuria or hemosideruria. Hemoglobinemia will lead to the development of or the spillage of the hemoglobin in the urine, leading to hemoglobinuria. The LDH will be released from the RBCs, and there will be low plasma haptoglobin because the haptoglobin is used up in neutralizing the hemoglobin. Let's talk about the peripheral film presentation. In patients with G6PD deficiency, because of the oxidative stress, the hemoglobin can get oxidized and they can accumulate in cells in the form of certain Heinz bodies. So Heinz bodies is specific for the diagnosis of G6PD deficiency. And along with that, because the Heinz bodies are not a normal presentation in any type of RBCs, the spleens, when it is properly functioning, it leads to capturing those Heinz bodies, or it takes up basically a bite of the RBCs. And that leads to development of these types of cells called the bite cells in the RBCs. So these bite cells are basically the spleen removing the Heinz bodies. You can see a few Heinz bodies here, here, and here. So when the spleen takes a bite of the RBC, it leads to these types of cells called the bite cells. These are the two important features to remember on the peripheral blood film: Heinz bodies and the bite cells. Along with that, there will be anisocytosis, which is basically a varied types of shape or the sizes of the cells. Polychromasia might be present. Spherocytes, a few spherocytes like these are present in these patients. The concentration is not greater, very much enlarged to diagnose them of hereditary spherocytosis, but there will be a few, like one is here, like one is here. Along with that, there might be bizarre poikilocytosis, in which there might be out membrane blebbing of the RBCs. The important two diagnostic peripheral features are the bite cells and the Heinz bodies. These two are the ones which I want you to take home from this slide. The other ones can be present in other diseases as well and are non-specific, but bite cells and Heinz bodies are specific for the G6PD deficiency. How do we diagnose this condition? The screening test is basically you look for the G6PD enzyme assay and the RBCs. It is a quantitative test, and this screening test is also basically the diagnostic test in which we quantify the RBCs concentration of G6PD enzyme. Along with that, various types of DNA testing can be done. The X-rays, because it is an X-linked disease, you can screen the blood relatives as well with the help of DNA testing. But the major diagnostic test is the G6PD enzyme assay with the help of a screening. Let's look at certain types of drugs that can lead to development of the hemolysis in patients with a G6PD deficiency. The important ones are the antimalarials, specifically the primaquine historically has been very much linked to the to causing hemolysis in these patients. Other types of antimalarials, newly developed antimalarials, can also cause the hemolysis in these patients. The primaquine is the one which was given historically to the patients, is the most common one concerned with the hemolytic anemia. Along with that, the sulfonamides or the sulfur drugs can cause the hemolysis. Then antibacterial, specifically the nitro drugs, are also the very important in causing, like the nitrofurantine used for the UTI or other nitro drugs. So the nitro, sulfur, and the antimalarial, these three are very important. Along with that, the antimalarials, you can give a patient like dapsone, which was used for leprosy in certain patients. It is also something which is very closely linked with the hemolysis in patients with G6PD. So dapsone is also very important drug to remember. Antipyretic, anti-analgesic, certain type of NSAIDs can cause, on a long-term basis, it can precipitate hemolysis. And like other drugs, like the newer drugs, like the rispuricase, which are used for patients in gout, can also cause the hemolytic anemia. So the important take-home are the antimalarials, specifically primaquine, sulfonamides, antibacterials like nitrofurantine, dapsone, antipyretics, anti-analgesics like the NSAIDs, and certain newer drugs can also cause precipitate hemolysis. How do we treat a patient with G6PD deficiency? Because it is an enzyme deficiency, it is very difficult to cure or treat that. We are basically managing the patient symptomatically. So if the patient is using a drug which can precipitate hemolysis, we can use certain alternative drug to that. If the hemolysis is too large to cause very enlarged and very greatly exaggerated anemia, or the hemoglobin reduces to a very low levels like to 5 or 6 value, we can transfuse the patient with blood or the RBC products, and then we also have to look for the iron overload with counteract that with the help of iron chelation. The antimalarial drug combination containing dapsone, we should avoid using these antimalarials which contain dapsone or the other uses of the dapsone. Dapsone is one which is very strongly related with the development of anemias. Use alternative drugs in someone who has developed a kidney problem or a renal failure, because renal failure is one of the more common causes of death in these adult patients. Hemodialysis can be employed to counteract that renal failure. Regular folic acid supplementation to avoid the development of anemia. Regular hematologic surveillance is very important to look for the extent of the anemia or what are the precipitating factors in this anemia. And finally, if nothing works, we might have to do splenectomy, because there is a certain although it is a majorly intravascular hemolysis, but there is certain role of the extravascular hemolysis as well in these patients. And by removing the spleen, we might be able to alleviate some of the symptoms caused by the G6PD deficiency. Certain other rare types of anemias related to the enzyme deficiency are the glutathione peroxidase deficiency. This is not very clinically significant, and what you have to remember is with the glutathione peroxidase deficiency, there will be inability of the H2O2 to be neutralized, and these patients generally present with an infantile poikilocytosis, in which there are poikilocytes in the peripheral blood film, especially in the infants, and they might have certain chronic hemolytic anemia, which is a low degree anemia, and this might not be clinically evident in patients, and this might be an accidental finding in these patients. The last topic of discussion in this long lecture is the familial hemolytic uremic syndrome. This is basically the only type of extra or the extrinsic defect outside of the RBC that leads to an hereditary problem. Hemolytic uremic syndrome, there are a lot of varieties. It can be a typical hemolytic uremic syndrome, which is because of the sugar toxin produced by the certain species of Escherichia coli or E. coli. Or it can be a familial, which is also called an atypical hemolytic uremic syndrome, which is a genetic problem or an inherited problem. The important clinical features are a triad of problem. In hemolytic uremic syndrome, what happens is there is an endothelial cell problem in the vessels, especially at the micro vessels. That endothelial damage leads to the consumption of the platelets, making a thrombus there. That leads to thrombocytopenia. So thrombocytopenia is one clinical important feature. Because of the formation of a thrombus in these small vessels, when the RBC passes through that thrombus, the RBC membrane gets damaged. And that can lead to an RBC deformation or a RBC hemolysis. So RBC hemolysis or anemia, along with thrombocytopenia. And the third thing is a renal failure or the development of uremia, as evident, hemolytic uremic syndrome. Uremia is basically because when the thrombus forms in the renal blood vessels, it compromises the blood supply to the kidney, and over a long period of time, it can lead to development of uremia or renal failure. So the triad of anemia, hemolytic anemia, thrombocytopenia, and uremia is the one which basically defines the hemolytic uremic syndrome. So there will be a thrombotic microangiopathy because of the thrombosis. The vessels will be damaged, and the RBCs there will be hemolysis because of the platelet consumption by the thrombus. There is a generalized thrombocytopenia, and that is evident by the thrombocytopenic purpura, the development of the purpura because of the platelet deficiency in these patients. And the whole picture of hemolytic uremic syndrome will be evident by the development of the uremia or the renal failure. There are various presentations. The typical hemolytic uremic syndrome, which we define as an acquired problem, is basically because of a sugar toxin. It is a toxin-associated problem. The sugar toxin is produced by the E. coli bacteria, and that leads to development of this syndrome. The one which we are concerned with today is the atypical hemolytic uremic syndrome or the inherited type of hemolytic uremic syndrome. These patients generally have an alternative complement pathway problem because some problem outside the RBCs in the complement pathway, it leads to the development of hemolytic anemia and then the whole plethora of thrombocytopenia and the hemolytic and the uremia develops. There are certain other secondary causes of hemolytic uremic syndrome as well. The list is exhaustive. The important ones are either in this develops either in patients with the stem cell transplant, bone marrow transplant. In certain patients, it can develop during pregnancy. It can be secondary to a drug use. Certain rare drugs can cause this problem. In someone who has a malignant hypertension with uncontrolled blood pressure can lead to the development of hemolysis and leading to the development of hemolytic uremic syndrome. Uncontrolled septicemia, especially in DIC patients, they can develop hemolytic uremic syndrome. And certain types of rare autoimmune disorders like lupus can also lead to the development of hemolytic uremic syndrome in these patients. Certain malignancy like the leukemias can cause secondary hemolytic uremic syndrome. And finally, the streptococcal infections in this spherocytosis form can also lead to the development of secondary hemolytic uremic syndrome in these patients. These are the basic exhaustive list of the secondary hemolytic uremic syndrome. And now, finally, if we don't find a cause or the reason underlying pathology, we classify it as an idiopathic hemolytic uremic syndrome. So the important thing here is regarding the inherited hemolytic anemia, the atypical hemolytic uremic syndrome, which is basically an alternative complement pathway problem leading to the destruction of the RBCs. So with that, we complete our discussion of the inherited hemolytic anemias. We started off by in the background of discussion of a case of a young girl, Hannah, 42 years old female, who presented with certain signs and symptoms. And through the course of the lecture, we discussed the various presenting complaints of that patient. How did we evaluate those symptoms? What are the various lab findings that were present in that patient? And based on that, how do we diagnose that patient of a case of hereditary spherocytosis? Then what are the various investigations that helped us in diagnosis? What are the various treatment modalities that we have? And how do we screen the relatives of that patient? Because that was an autosomal recessive disorder, autosomal dominant disorder. And then in the latter part of the lecture, we discussed certain enzyme problems like the G6PD deficiency. And then later on, we concluded our discussion with the hemolytic uremic syndrome. So to watch this complete lecture, along with thousands of other medical lectures on various topics like the clinical course or the basic sciences course on any area of your interest, log on to sqadia.com and start your free trial today. Thank you for watching.